Today I have the honor of presenting Dr. Walter Cholewczynski. He's the Director of Surgical Critical Care, the Chief of Wound Healing and Hyperbaric Medicine at Bridgeport Hospital, and is a Clinical Assistant Professor at the Yale School of Medicine. Dr. Cholewczynski grew up in Maryland and attended the University of Maryland, and then went to medical school at the Eastern Virginia Medical School. He completed his residency training at Maimonides Medical Center and completed his fellowship in surgical critical care at the University of Minnesota. He came to the Bridgeport Hospital in 2004. Please welcome him in presenting for us urologic indications for hyperbaric oxygen therapy. Thank you.
All right. Good morning. Thank you. Thanks very much for that introduction. I was asked to speak to you about hyperbaric oxygen therapy in relation to urologic indications. And so I thank you for this opportunity. This is sort of a niche medical treatment that I became interested in a couple of years ago when we started up our hyperbaric medicine program at Bridgeport Hospital. I think I probably got interested in it mostly because of a long time ago, being a scuba diver and then learning about pressure treatments for various medical conditions. And I actually became board certified in understanding hyperbaric medicine, which is also a very small group of people that carry that board certification. So today I wanted to talk about hyperbaric oxygen therapy, and I think I just hit the arrow to advance. Okay, so so if I can get rid of this thing here. I have a little thing blocking my screen. Anyway, so what is hyperbaric oxygen therapy? It's breathing 100% oxygen at greater than 2.0 atmospheres atmospheric for 90 to 120 minutes. So this is the equivalent of 33 feet of seawater, and it's an actual real pressure increase over what we're ambient pressure. And it's not a treatment at some low pressures of like 1.1 or 1.2 atmospheres. And it's not on air. It's actually breathing 100% oxygen to increase the our circulating plasma oxygen saturation. It's done in a hard-sided hyperbaric chamber, not in a tent where air is blown in, not like a little foot chamber. Of course, that wouldn't work for urology, but sometimes there are items available for sale, or that some practitioner utilize to put like a diabetic foot inside some sort of little device that has air blown into it, increased pressure. That's not hyperbaric oxygen therapy. This is a treatment done in a hard-sided hyperbaric oxygen chamber, managed by certified technicians and physicians and nurses who are familiar with the treatment of under pressure. So how does it work? Hemoglobin has a high affinity for oxygen. It saturates to 100% easily with supplemental oxygen. We're all aware of that. Some of you may remember that the arterial oxygen content equation that is something like 1.36 times hemoglobin times saturation. That quantity has a little plus on the other side of it at 0.003 times the PO2, which if the PO2 is 100, 0.003 is a very small number. It doesn't really affect us very much. But that is the amount of oxygen that's dissolved in plasma. And when you add pressure, 100% oxygen under pressure, that number goes up to a significant amount. And that is what hyperbaric oxygen therapy does. So it drives oxygen into the plasma, and so that you have dissolved oxygen in plasma. So you can get the PO2 up to 1,000 to 1,500 millimeters of mercury at pressures between 2 and 3 atmospheres absolute. 2 atmospheres is 33 feet. 3 atmospheres is 66 feet. We usually treat our patients at 40 feet of seawater. Now, When the person comes out of the hyperbaric chamber, that effect dissipates pretty quickly. So what's going on? Well, what's been identified is that there's a pharmacologic effect. It's like taking a medication. You get dosed with oxygen, that repeated dosing starts stimulating effects in the patient. And some people have, thought about it this way, that think of oxygen as a drug, and the hyperbaric chamber is a dosing device. It's dosing the amount of oxygen that the patient is getting. So diabetic wounds and post-radiation delayed tissue injuries are very common problems that we treat in hyperbaric medicine, in clinical practice. Of course, one of the famous indications is treating the bends and divers who develop nitrogen bubbles from surfacing too quickly. That's sort of a classic treatment that hyperbaric oxygen therapy is the definitive and only treatment for. But there are a lot of medical conditions that hyperbaric oxygen therapy is adjunctive therapy for, which we use in our clinical practice. There's not a lot of diving injuries here along the Long Island Sound coast. So in diabetic wounds, post-radiation delayed tissue injuries, which the second part is what's really more applicable to this audience, there's depletion of stromal cells, poor skin surface granulation on the skin, chronic inflammation, fibrosis, and a reduced supply of oxygen mediators to the tissues that have been radiated or are subjected to injuries in diabetes. Do you know how to take this little thing away? Because it's sort of blocking my ability to see my screen. Oh, thanks. All right. So hyperbaric oxygen therapy's impact on neovascularization. So growth of new blood vessels from local endothelial cells is enhanced, which is, of course, termed angiogenesis. There's recruitment and differentiation in the bed of the wound of circulating stem or progenitor cells that form new blood vessels, especially in wounds that have been subjected to radiation therapy and chemotherapy. It helps stimulate stem cell growth factor production in these affected tissue beds. Hypoxia-inducible factor is induced by hypoxia, but there is a it's sort of like a horseshoe effect that at very low oxygen tensions you have a hypoxia-inducible factor present, but also in hyperoxic settings. And it's been identified, bench research, that requires free oxygen radicals, which are provided by hyperbaric oxygen, to stimulate hypoxia-inducible factor, which can be a growth factor in wound healing. It also stimulates synthesis of growth factor beta-1 from dermal fibroblasts and basic fibroblast growth factor in ischemic limbs. There's a lot of cell mediator effects that hyperbaric oxygen or hyperoxia has on wound beds. Oh, it did not add this. No, it's not. Let's see what I have to do here. Okay. Hyperbaric oxygen's impact on inflammation decreases inflammatory mediators, leukocyte sequestration, TNF, IL-6, ICAM, CD18. A lot of these tissue myeloperoxidase, lipid peroxidation are all suppressed by hyperbaric oxygen. It induces other mediators such as fibroblast growth factor, collagen synthesis, VEGF, transforming growth factor beta-1, platelet-derived growth factor beta, and which are all upregulated by both hypoxia and a hyperoxia that you get from hyperbaric oxygen therapy. There's increased nitric oxide, but nitric oxide production by activation of inducible nitric oxide synthase with increased granulation tissue deposition, epidermal migration, and wound, helping to enhance wound closure. So the Undersea Hyperbaric Medical Society is our major medical society for these types of therapies. And the organization has gone through and done extensive scientific evaluation of various problems to determine what is acceptable for use of hyperbaric oxygen therapy. As many of you may know, that that hyperbaric oxygen therapy is sometimes used outside of medical circles for a lot of different things. There are 15 approved indications by UHMS for hyperbaric oxygen therapy. The ones that would affect this audience primarily would be delayed tissue radiation injuries, soft tissue and bony necrosis, such as irradiation cystitis, and also compromised grafts and flaps. So if you are doing reconstructive procedures with skin grafts or rotation flaps or tissue flaps that have compromised healing for one reason or another, hyperbaric oxygen therapy is an approved treatment to help enhance the healing of those flaps and grafts. Oh, so now CMS, Centers for Medicare and Medicaid Services, also is very much involved in this since they're a major payer for our older population. And CMS has a more restricted, they have 15 indications. Some of them are split out from some of the indications UHMS has. But it's actually a quite much narrower list that CMS approves and will pay for. But our irradiation cystitis and radiation affected wounds are in the list, as well as preparation and preservation of compromised skin grafts, which also includes rotation flaps and other tissue reconstructions that have compromised healing. So radiation injury. Acute radiation injury is due to direct cellular impact. It's self-limiting. It can be very debilitating. Typically lasts up to 2 months. Subacute radiation injuries are typically affecting the lung or spinal cord, have an onset of between 8 and 12 weeks and may last for several months. Delayed radiation injuries, which is the area that we're interested in for this topic, typically present after 6 months, but can present years later. It may be brought on by trauma or surgery in the affected tissue bed. Only about 5 to 10% of patients develop late radiation tissue injury. What happens in the tissue bed? In the tissue bed, there is an obliterative endarteritis. The radiation therapy destroys the small little blood vessels in the tissue bed that kills the tumor cells. That's one of the mechanisms of therapy against a carcinoma. But it can also affect the surrounding normal tissues. There's radiation-induced apoptosis and tissue fibrosis, elaboration of fibrogenic cytokines, resulting in a fibroatrophic effect with depletion of stem cells, parenchymal cells, and an exuberant fibrosis. Radiated tissues are often very woody and dense, and have a loss of compliance. So there's vascular damage, stenosis, and necrosis that can occur. A lot of numerous cytokines have been identified as being elaborated. However, there's no reliable predictor of which patients will develop late radiation tissue injury. So we can't really predict if we provide radiation therapy for this particular person with prostate cancer, whether he will develop late radiation tissue injury at some point in the future or not. So the impact of hyperbaric oxygen on the irradiated tissues is it promotes angiogenesis. It helps to stimulate regrowth of small little blood vessels in those irradiated tissue beds, and which helps improve tissue oxygenation, as you would expect. And it helps reduce fibrosis, reduces the scarring and the woodiness and the density of the tissues. And it helps increase mobilization, induction of stem cells. So those are the 3 main things that hyperbaric oxygen does to help reverse the effects of radiation on otherwise normal tissues that have been affected by it. Angiogenesis, reduction of fibrosis, and mobilization, induction of stem cells to repopulate those tissue beds. So the vascular effects been looked at in both human and animal studies. There's histologic improvement in vascular density after hyperbaric oxygen therapy, improved transcutaneous oxygen content and or saturation. This has been looked at by Doppler flow studies and microvascular fluorescence angiography. One of the first areas that was looked at for this category of problems, radiation injury, was in osteoradionecrosis of the mandible. And an oral surgeon, Dr. Marks, was an early investigator in this and developed protocols for using hyperbaric oxygen therapy to treat patients who had who had oral cancers that were treated with radiation therapy, and then later on developed problems with mandibular necrosis, either as a direct result of the radiation therapy and local tissue injury, or after like dental extractions. And then with the dry sockets, end up developing problems with mandibular necrosis. And he identified that with addition of hyperbaric oxygen therapy to surgical management, that there was an improvement in oxygen and vascularity and blood flow to the tissues that enabled the healing that they observed. Fibrosis stem cell effects of hyperbaric oxygen, again, in studies both humans and animals, there's decreased fibrosis, increased compliance of tissues, nitric oxide mediated elaboration of stem cells. And as I just mentioned, the first studies for this application were in osteoradionecrosis of the mandible. This is just a graph showing the vascular density of irradiated tissues, the function of hyperbaric oxygen exposures. The top line is a normal, and the bottom line, you can see that the vascular density in radiated tissues was extremely low, and after hyperbaric oxygen therapy, they would identify that there was significant improvement. This is a problem that I'm sure everybody in this room is familiar with. The telangiectasias that occur in the bladder from a patient with irradiation cystitis and hematuria. So radiation cystitis, now I'm talking to the group who knows this the best. I know this secondarily because you send me patients with this problem. So I will defer to this audience about any specifics of this, but may result from radiation treatment to pelvic organs after treatment for prostate cancer, bladder cancers, rectal cancer, GYN cancers. So women, of course, are also can also develop irradiation cystitis, as well as other pelvic organ radiation tissue damage that we treat sometimes patients with irradiation proctitis and other problems. But sticking with the bladder, I found a reference that the incidence of irradiation cystitis is 23 to 80%. However, severe hematuria is in a much smaller number of patients, 5 to 8%. So this is another area where I defer. I'm not sure how many of these treatments are used, but identified that conjugated estrogens, pentosan, WF10, are sometimes used, intravesical treatments with alum or other agents, cystoscopy with fulgurating the bleeding points. And then a number of patients have undergone urinary diversion with percutaneous nephrostomy. And I don't know how frequently you resort to angioembolization of internal iliac arteries. And then cystectomy would obviously be a very severe treatment for uncontrollable hemorrhage. The 1995 Beavers, Kurth, and Backer published an article on the use of hyperbaric oxygen therapy for radiation cystitis with hematuria. They treated 40 patients at just under 3 atmospheres atmospheric for 90 minutes times 20 sessions. 4 patients underwent 40 sessions for persistent hematuria. All had undergone other therapies prior to starting hyperbaric oxygen therapy. The patients had pretty significant hematuria. The mean transfusion in this group was 8 units of blood. 30 patients had complete resolution, and 7 had significant decrease in hematuria with hyperbaric oxygen therapy. So they found that this was a very helpful adjunctive therapy. It's not a primary treatment, but as in combination with medical and surgical management, they identified that this was a viable way of treating these patients. Subsequently, there was a number of investigators who looked into this. Feldmeyer and Hampson. Feldmeyer is a radiation oncologist who is a past president at the UHMS. They did a systematic review of 17 articles where they pooled all the patients and identified that 76% of the patients treated in those publications, mostly case series, had resolution of their hematuria with hyperbaric oxygen therapy. Corman, 57 patients treated, 80% complete or partial resolution. This is the Corman, Chong, and Hampson are the group from in Seattle. Escapes me the name of the clinic there. But they have been using hyperbaric oxygen therapy with very good results, as you can see. Improvement in resolution from 80 to 96%. Hyperbaric oxygen therapy started within 6 months of hematuria. So one of the things I identified is don't wait to add hyperbaric oxygen therapy to the treatment. Start it early. And it also decreased the incidence of clot retention when hyperbaric oxygen therapy was added to the treatment regimen early on. And they're talking early on, 6 months, but I would encourage you to send the patients earlier. So I think that you'd probably prefer, and the patients would prefer the add on a treatment like this earlier in the process. Some more articles and more recently, Cardinal did another review of articles, 602 patients in this review, 84% had complete or partial resolution, and 14% of the patients that had 12-month follow-up had recurrence sometime in the 3 to 10 month range, and those patients can be treated again with another course of hyperbaric oxygen therapy. Oscarson published an article in 2019. It's a randomized controlled trial. They randomized half their patients to hyperbaric oxygen therapy and the other half to other treatments, excluding hyperbaric oxygen therapy. And using the expanded prostate index composite score, EPIC score, the patients that were treated with hyperbaric oxygen therapy had a change of slightly greater than 10 points versus 7.7 in controls, which was identified to be statistically significant. I'm not sure how much you use the EPIC score in clinical practice or your familiarity with it. I had not heard of it before, but so what is our regimen? So typically we would treat patients with radiation cystitis for 40 sessions. With the treatments are 5 days a week, Monday through Friday. So each month has approximately 20 days, 22 days. So this is talking about like 2 months of therapy, patients going into the hyperbaric chamber. We treat in most centers around the country, treat at, actually that is incorrect. It's 2.2 ATA for 40 feet of seawater for 90 minutes with 2 5-minute air breaks. We give the air breaks to help minimize the incidence of oxygen-induced seizures, which we don't see at this treatment regimen of keeping the patients at 2.2 atmospheres for 90 minutes of oxygen therapy with the air breaks. Sometimes the patients have persistent hematuria. I'll increase the sessions to 60 or 80. Pretty much by the time you get to 80 sessions, you have maximized the benefit of hyperbaric oxygen therapy. Patients can be retreated for recurrent hematuria, and that's often successful. This is some pictures. This larger chamber is our chamber at Bridgeport Hospital. This is a multi-place chamber. We're the only multi-place chamber in the state of Connecticut outside of the naval base out in New London. And this chamber can fit up to 6 patients with one of our technicians inside with the patients. The top one is a representative picture of a monoplace chamber, and I wasn't able to get a picture in time for this presentation of our monoplace chambers at Milford campus. We have 2 monoplace chambers. The multiplace chamber is compressed with air, and the patients wear hoods and I'm not sure if this will work, but there's some, they wear these clear plastic hoods and they breathe oxygen through those hoods during the treatment. And then at every 30-minute interval, the technician assists the patients with popping the hoods off so they can breathe air under pressure. And then hoods go back on, and they do that two cycles. In a monoplace chamber, the monoplace chamber is obviously much smaller. One person goes in, a person reclines, and the chamber is compressed with oxygen. And at 30-minute intervals, patients put on are directed by the technician outside to put a face mask on and breathe air through the face mask to help ameliorate the effects of being on oxygen for such a prolonged time at such a high pressure. All right, and this is us. We have 2 sites, Bridgeport Hospital and at Milford campus. We have 2 chambers at Milford campus. We can do three different time periods, so we can treat up to 6 people a day at Milford. At Bridgeport, we can treat like up to 6 patients at a time in our hyperbaric chambers. We can treat 12 patients a day there.